Okay, so dengue is an infectious disease which is caused by dengue virus, and dengue virus is flavivirus. There are four serotypes of dengue virus, and principal vector of dengue is Aedes aegypti, and the most common arthropod borne viral infection is in humans is dengue. So incubation period of dengue virus is 2 to 7 days following mosquito bite with a heterotrophic immunity, and there are certain clinical features of dengue, like prodromal illness of malaise, headache, myalgia, arthralgia, fever will be there, and there is also breakbone fever, which is generalized pain and pain on eye movement. So these are most important clinical features because a fever must be differentiated on the basis of these type of clinical presentations. So patient will have fever means increased temperature, then patient will have arthralgia, joint pain, headache, pain on eye movement, generalized pain, which is also known as breakbone fever, means pain and pain on eye movement. It will be there. Nausea, vomiting, relative bradycardia and lymphadenopathy will be there in the patients of the dengue. So the test for diagnosis of dengue will be tourniquet test, in which petty keys are counted because dengue causes thrombocytopenia, and for fever it is continuous fever, not like step-ladder pattern of the fever in typhoid, and saddleback fever is present which breaks on fourth or the fifth day, and there is critic phase also is present there, in which period is 3 to 7 days after onset of the fever, and there is also a dengue shock syndrome develops. Rashes are also present because of thrombocytopenia, maculopapular rashes with mobiliform rashes that blanches on the pressure and spreading centrifugally, spreads on palm and soles. And dengue hemorrhagic fever is a form of fever in which there is sequential clinical features they like thrombocytopenia, hemorrhage, hypotension, circulatory failure, pleural effusion, ascites, hypoalbuminemia, and acute respiratory distress syndrome occurs in this type of dengue. Diagnosis of this will be on the basis of CBC shows leukopenia and thrombocytopenia most commonly. Confirmatory test will be fourfold rise of IgG antibody and detection of dengue virus by RNA on PCR. So the management of dengue will be treat the symptoms. If there is fever, give antipyretics. If there is thrombocytopenia, then we will have to manage this, and I also avoid the aspirin and large volume replacement with blood transfusion in patient of the shock. Corticosteroids have not been shown to help, so they are not so much effective, and the prevention will be breeding places should be maintained, and adult should have killed by insecticide, and there is no vaccine for prevention of the dengue. So in this way we can treat the patient by giving supportive treatment like platelets should be given to the patient and antipyretics should be given, but one thing must be kept in mind that aspirin is avoided in dengue in order to uh, prevent the risk of bleeding. Okay, so malaria is caused by Plasmodium malariae and transmitted by the bite of female Anopheles mosquito. There are different species of the malaria like Falciparum vivax, P. ovale, P. malariae. These all species causing different types of malaria, and different complications occurs because of these species. So the life cycle of the malarian parasite is divided into pre-erythrocytic, erythrocytic sporopony, and the clinical features of malaria are highly dangerous, and most common malaria occurs, and that is falciparum. Now, high-grade fever is accompanied rigors and drench sweating. Fever has no pattern. In malaise, headache, vomiting occurs. Jaundice along with hepatosplenomegaly with anemia and thrombocytopenia occurs in this type of malaria. Falciparum malaria causes cerebral malaria most commonly, and cerebral malaria is associated with this type of species, and progress to coma. Cerebral malaria progress to coma, and then death occurs because of this type of malaria. And black water fever also occurs because of falciparum malariae, in which dark urine because of hemoglobinuria is passed with widespread intravascular hemolysis occurs. And other complications are severe anemia, DIC, acute respiratory distress syndrome, hypoglycemia, metabolic acidosis, gastrointestinal diarrhea, jaundice, and splenic rupture occurs. Clinical feature of the falciparum malaria is a quartan fever associated with glomerulonephritis, PYX, oval, benign tertian malaria, and fever spikes for every 48 hours with tender hepatosplenomegaly relapses for many years. And the diagnosis is GEMSA thick thin film and thick thin film with rapidic taste also, and there is immunochromatographic tests are also performed. So the treatment for malaria, PYX oval and P. malaria, the treatment will be chloroquine is the drug of choice for all these three species. And chloroquine treatment regime is chloroquine 600 milligram should be given. If 300 milligram is given, then 6 hours later 300 milligram, then 24 hours, then 300 milligram for next 24 hours. So in this way, treatment of malaria is done, and the primaquine is also given. And for falciparum, if there is resistance to chloroquine, then sulfadoxine and pyrimethamine should be given. So in this way, treatment of malaria is done. The drug of choice for falciparum is artemisinium, and artemisinium based chemotherapy and quinine should be given, and the regime of co-artemether is given. In regime 2, quinine, doxycycline, clindamycin, and atovaquone and proguanil should be given in the tablet form. If complicated P. falciparum is there, then IV artesunate should be given, and quinine salts should be given in the malaria. So in this way, malaria can be treated. Okay, so the infectious disease is Kala Azar. It is also known as visceral leishmaniasis, caused by protozoan Leishmania dinovoni complex, transmitted by phlebotomine sandfly, and its incubation period is 1 to 2 months. But some of its species may be of several years. And clinical features of sandfly and the leishmaniasis is fever. First of all, fevers occurs along with rigors and chills, then massive splenomegaly, hepatomegaly, lymphadenopathy, blackish discoloration of skin, edema, ascites, hematological abnormalities like anemia, thrombocytopenia, and pain cytopenia occurs, and the diagnosis will be CBC, pancytopenia along with granulocytopenia, monocytosis. LFT shows hypoalbuminemia. Immunology shows hypergammaglobulinemia, and splenic bone marrow, lymph node, and liver biopsy is also done. And there is also this biopsy shows the amastigotes and Leishman denovan bodies in the biopsy. So the treatment for this disease is drug of choice should be given is antimony salts or sodium stibogluconate, and resistant case there should be IV amphotericin B should be given. Other regimens are miltefosine and paromomycin or pentamidine should be given. So in this way we can treat leishmaniasis. Okay, amoebic liver disease is caused by amoebiasis, and a trophozoite enters into portal vein and then circulates through the large bowel mucosa. Then its clinical features are right upper quadrant pain, pain radius to the right shoulder, tender hepatomegaly with in contrast to the pyogenic liver abscess, there is absence of toxicity, high fever, swinging pyrexia, and single abscess affects the right lobe of liver most commonly. And the complication of pyogenic liver abscess is rupture into the lung and pleural cavity, then rupture into peritoneal cavity and pericardial cavities is less common. Diagnosis of this is CBC, and CBC shows neutrophil and leukocytosis. Ultrasound abdomen visualizes liver abscess. Detectable antibody in 95% of the patient is also there. So the treatment will be metronidazole and deloxynate furet, and surgical drainage is necessary. If failure occurs, then medical therapy is started, and if there is a presence of complication, then medical therapy is started. So in this way, pyogenic liver abscess can be treated.